record visual acuity, because any referrals that I receive from them of such cases or otherwise on first post-operative day or second, third, for whatever hesitation, they don't record visual acuity. I'll request Dr. Nayak to highlight the importance of visual acuity as a sensitive indicator for infection, as he had said before also.
Now, visual acuity in post-operative cataract patients is definitely very, very important. Each and every visit I get it recorded. And it's a thorough recording of visual acuity, because it helps in two ways. One is, suppose the first day the patient's vision was better, and then if it has gone down, then definitely say your antenna should be up, that there is something wrong. Or if already is diagnosed or some reaction is going on, then in that case this becomes a very good indicator that whether treatment is working or not. So for both indications, probably you have to do every
Lalit,
time visual acuity thorough examination.
Lalit, can I have comments on you on this?
Ophthalmologist not recording visual acuity is akin to cardiologist not auscultating. You see, the patient comes to you for vision only. So it is also important from medical legal point of view. You see, all patients have to have BCVA recorded on each visit, in fact. This is what we inculcate in all our fellows and residents also.
How do you consider visual acuity as an indicator of recovery? You are treating a case of post-operative endophthalmitis. Do you think that this is an important sign of recovery of infection?
Yeah, I was coming to that. As soon as, suppose I have given intravitreal yesterday, I call him the next post-op day, next first day. If I see smile on the face of patient, that itself tells me that he is on the waiting area. He says, Dr. Sahab, achha hai pehle se. This itself says vision is a shade better than what it was yesterday. So this is very, very important therefore.
Thank you. What I wanted to highlight, that even if the other physical signs persist and they are not showing an appreciable regression, but if the visual acuity has improved following an intravitreal antibiotic injection, this is a great indicator of recovery, and this should be a relief both to the patient
Sir,
and
one
the
more
doctor.
point about this. It's not just when you're following up an endophthalmitis. Your cataract patient, if you know the patient's vision is improving on a subsequent follow-up, you're comfortable. But supposing you have a patient who was at an improved level of visual acuity and shows even a minor change for the negative, it's your first indication that something's going on, especially if this change occurs in the first 2 weeks, because you don't get CME in the first 2 weeks.
So that is
very
to
important.
emphasize thoroughly now the importance of visual acuity. Now this is a table that I have taken from a write-up which Dr. Lalit had published way back, and this was pertinent then. They said they compared the infection features and inflammation features. They said fundus glow is poor or absent when there is infection, and it is okay or mildly poor. Color of exudates is yellowish and it is white. Actually, this belongs to times when we were not doing modern surgery, and they probably address cases coming to their center infected elsewhere and presenting to them late. And that's how they were attempting to make a differentiation. To my mind, with all respect and appreciation to Lalit, it's not relevant today.
This is 2 decades old, sir.
Right. Let us compare starting from cornea right up to the posterior segment features, and let us try to see what we can call as infective and what we can call as inflammatory. Corneal edema can be because of inflammation, can be infective, and it can be a surgical edema also if there has been a prolonged phacosurgery. Corneal infiltrates are invariably infective. If there is flare alone, it is likely to be inflammatory, but if flare is with cells in anterior chamber, it is more in favor of infection. And if there are cells both in anterior chamber and vitreous, it is infective. Cells in vitreous are infective, and a hazy vitreous, as Dinesh commented, is invariably infective. Hypopyon can be infective and inflammatory. We have already discussed first day hypopyon and a hypopyon on second or subsequent days. Having described these signs and their relative importance to my judgment, I'll request Dinesh that out of these signs, which sign or a combination of which signs will be your go sign for intravitreal antibiotic?
In fact, one is the absolute value of the sign. The second is the development of a sign. So that's why the follow-up from day 1 is very important. So day 1, day 7, 3 weeks are critical points of evaluation, but with a caveat, SOS also. Any deterioration by the feeling by the patient, he must come immediately. Any of these symptoms, any of these signs increasing during a follow-up are a very strong suspicion of endophthalmitis. For example, if you had no cells and you develop cells on day 5, first sign of infection. If you have cells in the vitreous, definitely a sign of infection. And if you have a hazy vitreous, a sign of giving immediate need for giving an intravitreal.
Dinesh, out of these, which will you pick up as your go sign?
Yes. Now, if I have to use one, if I'm talking in terms of giving an intravitreal, for me, number one is hazy vitreous. Even mild haze is enough for me.
Okay.
But cells in vitreous are the first indicator that I must keep this patient under very, very close follow-up, maybe even every 4 hours. And if I see a deterioration occurring, he needs an intravitreal.
All right. Lalit, for you, which is the go sign?
I agree with Dinesh. One sign, if you have to point out, is cells in the vitreous cavity. AC cells can go either way, but cells in the vitreous, immediate, Saturday, Sunday, immediate attention should be given. Don't wait for Monday to come. Saturday itself, intravitreal should be given.
I think if it is a Saturday, please give the intravitreal. Because
Dr.
the
Nayak?
Sunday is a problem.
Dr. Nayak?
No, definitely whatever I said, absolutely true. Means I will only suggest that one has to have very high index of suspicion towards infection. You may err towards the infection side, but not the other way around. So you have to be more careful.
So what I follow out of the statements from 3 of them, that if there are cells in the vitreous, this is almost an absolute indication for giving intravitreal antibiotic.
100%.
Unless and until you can thoroughly justify these cells by some other pathology.
Yes.
Right. Now, importance of intravitreal injection cannot be overemphasized. Let us show you a case. This was referred to us from elsewhere. Patient had already received several subconjunctival injections, maybe hourly to hourly basis. This was the presenting picture, and a poor fundus picture could be obtained. We gave intravitreal antibiotic, and this is picture at 36 hours. Visual acuity improved to 612, and a good fundus picture could be taken. So that is to tell you that intravitreal antibiotic given in time really works as a magic, and it is possible to have as good visual outcome as in a case where no such pathology or infective pathology had taken place.
Sir, this should also discourage the routine usage of, once you're suspecting endophthalmitis, routine usage of subconjunctival antibiotics.
Yeah, I am doing
Because subconjunctival antibiotics, what they achieve is similar concentration as topical drops.
Topical drops. And this only adds to fibrosis, and this can alter the clinical picture also. Now, there have been studies, and there is a popular trend also at several centers, that they mix an antibiotic in a certain dose in the irrigating solution. Do you do that, Dr. Nayak?
No, so far, of course, this, according to this study, it is recommended, but so far I have never used even a single patient antibiotic in the irrigating solution.
Irrigation. Dr. Lalit, at your center?
Irrigation fluid, there is no level 1 evidence at all. But intracameral antibiotic as a prophylaxis, there is a very strong study which you have mentioned, European study, the cefuroxime, there is a 22 times reduction in end-off.
Dr. Dinesh?
Yeah, well, we work in the same center. We're giving intracameral Vigamox after a cataract surgery.
Okay.
Incidentally, this doesn't mean I'm giving it because I don't do cataract
Okay.
surgery, but the cataract surgeons are giving it.
Okay. Now, this course is actually has generated out of the fact that the anterior segment surgeons still have some hesitation in giving an injection through pars plana. If a pars plana injection was a must part of the curriculum of phaco courses, probably we will not require to be here to present this course. Now, I wish to emphasize that giving a pars plana injection is technically safer than giving a peribulbar injection, which you all give for obtaining ocular anesthesia and akinesia, because everything that you do in giving an injection through pars plana is done under vision and view. Now, this is a debatable thing, that it is recommended that we must obtain a tapping from the anterior chamber and a vitreous sample, send it for culture and sensitivity. With the result, it has been my observations that many good anterior segment surgeons have delayed giving antibiotic till the reports of culture and sensitivity are brought to them. Can I have a comment from Dinesh? Should we hold till the culture reports or we should not?
I think there's absolutely no indication. 48 hours is enough to destroy an eye. So there's no question of waiting for a culture report to give an antibiotic. The antibiotics have to be given on the presumption that you're giving something empirically, which will be a combination of a gram-positive and gram-negative coverage. And that vancomycin, ceftazidime is what is the usual coverage which we've been giving. The culture report is something that you use or we use for subsequent treatment.
Changing the antibiotic if it's...
Supposing I'm not getting a response and you want to see whether I need to add something else or change something else, that's when you use.
But 60% of the culture sensitivity reports are sterile.
Yeah, the problem, in fact, my first question would be, how would you take the culture?
That I am asking
For
Lalit again.
no, the reason I'm asking you this, I'm asking this is because to take a culture, a sample from the vitreous, actually needs a 21 gauge bore at the very minimum, and I would not recommend that, it causes traction. Therefore, taking a culture is the work of a vitreous surgeon. It is
Lalit,
not the
can
work
you
of
suggest
Sir,
both AC tap and vitreous sample to be taken, and what's your technique for taking vitreous sample, and which is important, vitreous or AC?
The best, as Dinesh was hinting in this last sentence was, best is vitreous biopsy, in case anybody can do. Like that is, like he said, domain of vitreous surgeon primarily. Unless you have that intractor which was available a couple of years and it's not freely available also. So vitreous biopsy gives the best yield without the complications of traction. The 21 gauge I would never recommend because whosoever uses, in fact even vitreous surgeon uses, is fraught with complications of creating future retinal dialysis or some traction onto the vitreous base. So it's an emergency procedure. What you need, because Dinesh said 2 antibiotics are required, you need to decompress. So what I would recommend for a comprehensive surgeon is, do not do any vitreous maneuver, just give 2 antibiotics after depressing, after taking paracentesis. Because paracentesis has to be done. Otherwise, you can't adjust 2 antibiotics.
So
and why it is required is because it is medico-legal significance
That's
also.
right. Message is that for initiating treatment, we don't have to wait for culture and sensitivity report, but you must have it so as to be medico-legally sound. You must record the visual acuity also, you must inform the patient also, and send samples to the lab. Now, corticosteroids have been advised topically, intravitreally, systemically. What will be, we'll discuss later that where to give. My question to Dinesh is that which situation he will absolutely contraindicate use of steroids in any form.
Okay, let's start from the topical, because that's what comes first. If there's a corneal infiltration, I'll not give topical steroids. That's
Okay.
the first thing. As far as systemic steroids is concerned, I'll normally start that 24 hours later after starting the giving the intravitreal and after starting the topical therapy. Other than corneal infiltration cases and other than where I actually strongly suspect fungal, I will start topical steroids, but not in a very high percentage, not in a very high dosage. That means I'll give it 4 times a day along with cycloplegics, and then see what kind of response I'm getting.
Can I interrupt? Lalit, I'll never like to use steroids in any form once I suspect a fungal infection.
No, fungal is different.
Not even, I mean, spacing them hours apart.
No,
or-
not in fungal. Fungal you will not give.
Right, so you said that you will...
No, I said if I suspect fungal, then steroids are contraindicated.
Absolutely contraindicated. Okay. Do you give intravitreal steroids ever, Lalit, along with
If I am
intravitreal
100%
antibiotics?
sure, if I am 100% sure I am dealing with bacterial endophthalmitis, I may. I may, because all inflammations or infections have itis part, that is inflammation, and it has been shown by various studies, including one from L.V. Prasad also, that if you add 2 intraocular antibiotic steroids, the functional recovery is faster because of the itis element being taken care of in a quicker way.
There
But
are
the
2 situations. One is that we give first intravitreal antibiotic injection, observe the patient on first and second post-operative day, and we notice that the patient is certainly improving and the infection is getting controlled. And then we give an intravitreal dexamethasone to hasten recovery and to suppress the element of inflammation. This is one
I
situation.
don't do that. I don't do that.
You don't do
I
that.
don't do that.
Dr. Nayak? The second situation is that you give all the 3 injections in one go. So what
But
is
only
your choice?
Only caveat there is, if you give all 3 cocktail in the first go, you have to be pretty sure that you are ruled out fungal.
Okay. No, Dr. Nayak, what is your
Say
choice?
First time, always there is some suspicion in mind that to give a steroid along with, because if the infection is in a situation where antibiotic is not covering the organism which is there, or, I mean, so in that situation, and fungal infection, of course. So that's why I will not recommend the first time it should be given. But then definitely if the antibiotic is working, in case you have to give the
Let's poll.
Yeah.
He does not want to give it first time. Lalit says that if he is sure that this is a bacterial infection, he will give it in the first go itself. Dinesh?
I wouldn't give it, and the fact is the flora in Indian cases has been almost 20% fungal. So
All
it's
right.
just not worth taking a chance.
So the panel decides that in the first go, intravitreal dexamethasone is not to be given. You may assess the case after 2 days and then you may give, okay? Now the choice of antibiotic most popularly is this. At one time we were giving amikacin, tobramycin also. What is the choice of this panel, this or any of these?
I think this is routinely followed everywhere, Vanco Kefta.
Cefta and Vanco is the choice of antibiotic.
The only one caveat I would like to put here.
Yes, sir.
Actually, that is the routine, and especially if it's early endophthalmitis, which we are trying to catch, this would be my primary choice. If you're dealing with a severe endophthalmitis and you don't have a facility for doing a vitrectomy, then maybe amikacin is a better choice because the resistance to ceftazidime is increasing.
That's right.
And you're more likely to be dealing with a gram-negative organism if you've got a very severe infection not
Agreed,
coming
sir.
under control.
Absolutely agreed. Now, I have seen in medical colleges, people giving intravitreal antibiotics as a bedside procedure. And I have seen in certain private setups, people giving this in the OPD chamber also. To my mind, it should be given in operation theatre because reason or logic is that before we have obtained the culture and sensitivity reports, we are treating a case of presumed infection, right? It is otherwise not an infected eye. It's a presumption that the eye is infected. I'll request Lalit to tell us how does he give intravitreal antibiotic and where?
Sir, all intravitreal injections, whether antibiotic or even Avastin intravitreal, I give it in the operation theatre. Further, patient who has infection, believe me, he and his family is psychologically disturbed. So if I do it in the office, which I have never done in my life and never advocated also, neither any member of our group does it, we take him to the operation theatre, treat it as a surgery only, and all this is generally done under topical and explain to him everything. But since 2 antibiotics are being given, so AC decompression is a must. And always pay attention to the wound also. If there is a complicated surgery done, or the wound has been extended, there is a chance that IUP may rise and it may gape. So rarely it may require a suture also. So therefore attention has to be paid to the wound, IOP, and it has to be mandatorily done, believe me, in the operation theatre.
All right. We have already discussed that visual acuity is the first sign which indicates improvement, and thereafter corneal condition improves, flare goes down, cells reduce. Dr. Nayak had already commented on this. There is a trend for repeating intravitreal injections, and that is mentioned in the literature also. I personally do not believe in it, but I'll request Dr. Dinesh to comment. Do you repeat intravitreal antibiotic in any occasion, or if the treatment has failed, you take for vitrectomy?
You've given the first intravitreal, patient is improving, you don't need another intravitreal. You've given an intravitreal, patient is deteriorating, you already done a wrong thing. Why was this patient with you for so long that he's lost his best chance to go to a vitreoretinal surgeon? The role that you're playing in this process is to give the first intravitreal without a delay. You're not, second intravitreal is something which is a desperate measure. You have no facilities for a vitrectomy, patient cannot go for a vitrectomy, or the patient has a very severe corneal involvement and the patient cannot undergo a vitrectomy. Now these are indications when you would consider a second intravitreal. Other than that, the patient should have had a vitrectomy, not a second intravitreal.
Failure
so this is
of
very
intravitreal
important.
antibiotic should be followed by vitrectomy, Lalit?
Sir, the threshold for vitrectomy is going down. Because if I am clear that, you see, one is primary vitrectomy, one is secondary. Secondary is to take care of opacities after the infection dies down. Primary vitrectomy threshold is decreased.